I'm Kathleen Dom. The didactic portion of this tele-echo clinic is being recorded by AmeriHealth Caritas and will be publicly displayed for later viewing. We do not expect to disclose the identity of any of today's participants through this recording. However, incidental disclosure could occur, such as through a display of names of participants. Please refrain from posing any questions or making any comments during the didactic portion. By participating in today's tele-echo clinic, each participant is giving consent to being recorded. Please disconnect now if you do not agree. Reminder not to share PHI during this tele-echo clinic. Use of HIPAA-protected health information is strictly prohibited both verbally and in writing during tele-echo clinics. The information shared during this tele-echo clinic are from peers and experts in the medical community, and these recommendations are not binding. We hope this discussion is helpful to you in the continued care of your patients.
Thank you, Dr. Dom. So today we have Dr. Sheila Woods presenting on suicide risk assessment and prevention initiatives. We're going to invite you to make comments and questions in the chat box, which we will be monitoring. However, when Dr. Woods is speaking, we ask that you hold questions that are asked verbally for the end. And what we will do is be keeping time so that Dr. Woods' presentation will run about 15 to 20 minutes, and then following that, it will be open to conversation and questions for about 10 minutes before we switch to the case presentation that Dr. Dom will be presenting today. Shannon Tompkins from our clinical education team is providing technical support. So if you have any technical issues, please write those in the chat box and Shannon will be monitoring those. I want to welcome you on behalf of AmeriHealth Caritas and Select Health of South Carolina. We are the Project ECHO team for AmeriHealth Caritas, which is the parent company for Select Health of South Carolina. I am the Director of Behavioral Health Integration. My name is Cheryl Stockford, and I'm so pleased that you're here to join us today for the South Carolina Foster Care Project ECHO series. And with that, I'm going to welcome Dr. Woods.
Thank you very much. I appreciate the opportunity to talk on this important topic. I have no financial disclosures or affiliation with any commercial interest. Today, we're going to talk about the use of suicide screening tools and review how to do a suicide risk assessment and review a suicide prevention plan. Pediatricians and suicide, frankly, pediatricians encounter this issue frequently. 80% reported having a patient who attempted or died by suicide in a past year. And the bottom line here on this slide is that only 61% of pediatricians always screen for suicide. 37% screen some of the time. So I think in South Carolina, this 61% is probably significantly higher due to the Q-tip efforts to promote screening for suicide. No one else can play your part. In the 2019 high school student review from the Youth Risk Behavior Survey, the South Carolina high school students, 39% felt sad or hopeless, higher than the US overall numbers. Seriously considered attempting suicide, about 20% of our high school students. About 16% made a plan, 11% attempted suicide, and 2.5% resulted in some type of an injury that required being treated. The bottom line for suicide, I think, is that the initial thing that happens are the ideations or thoughts. And this may also include some non-suicidal self-injury. Then there's the attempt and ultimately the death, which is what we are most trying to prevent. The non-suicidal self-injury, which frequently is seen in the pediatrician's office, sometimes as a sort of noticed thing on a patient. It's not something they necessarily present with, but it's intentional destruction of their body. You've seen cutters, you've seen people who've attempted to hurt themselves in other ways. And a significant percentage of these injurers do attempt suicide eventually. Those most at risk for non-suicidal behaviors going on to suicidal behaviors are those where there's co-occurrence of physical or sexual abuse, or where either type of abuse was a continuous event in that person's life. And the self-harm that happens is due to a powerful urge, and patients will describe this to you as saying, I couldn't stop. I had to do this. It relieved me in that moment. Sometimes these injurers go to injuring themselves to actually reduce suicidal risk. What we need to know is that about 48% of suicide attempts occur with very little planning, within 10 minutes of a crisis. So in pediatrics, suicide attempts are impulsive, and they're a response to usually a psychosocial event that they consider a crisis. The good news is that 90%, so 9 out of 10, do not go on to die by suicide later. But what really matters is how intense their intent is and what means they are thinking about using in a suicide attempt. So what we know in the United States is that firearms are the most common cause of deaths in South Carolina and the United States. Suffocation, which is hanging sometimes, is the second most common cause. And poisoning is the third most common cause of suicide deaths. And that's usually associated with overdoses of medications. There are other types of injuries, but by far and away, firearms cause at least 50% of deaths. And this is just a look at deaths from 2010 to 2019 in South Carolina. And we've, of course, had an increasing number of deaths total over the years, significantly more males than females. And firearms are the most common choice for death by suicide. Suffocation or hanging is second, and poisoning is third. Overall, suicide deaths in age 10 to 34, which is of course the group that the pediatricians see, is the second leading cause of death in that age group. In the United States, it's also the second cause of death in that age group. In the younger age group, 5 to 12, in overall United States, it's the fifth cause of death. We did not, fortunately, have many of the 5 to 12 age groups, so that is not ranked in the numbers. It does matter how we talk about suicide. Instead of saying committed suicide, it's better if we just say died by or died of. And consider saying a suicide attempt or a suicide death rather than using the terms successful or unsuccessful. And then when we describe behavior of a patient who is attempting suicide, instead of using adjectives like manipulative or borderline, it's better to just describe what actually happened. Diagnosis, what the actual diagnosis is, if it's depression or social anxiety disorder, whatever, instead of using terms that tend to be negative. The other thing is that when a patient is not ready to engage with you about preventing suicide, we can say they're not ready to engage instead of treatment resistant or in denial or non-compliant. The current trends, American Indian, Alaskan Native youth have the highest youth suicide rates. We have very few of these youths in the South Carolina population. Black teens have the fastest growing suicide rate. And the other group to really be concerned about are the LGBTQ youth, they are 5 times more likely to have attempted suicide compared to their heterosexual peers. And the best prevention is strengths-based. In other words, focusing on what the patient and the family strengths are, and also being culturally sensitive in that suicide prevention. There is no one-size-fits-all protocol. And what I'm presenting is a risk assessment and prevention plan that can be used in your outpatient offices and also can be used inpatient. But bottom line is you use the screening tools, you interview the patient, you assess the patient if the screening or the interview is positive. And in that assessment, you're really identifying what the risk and protective factors are for that patient. You conduct a suicide inquiry, which we'll talk about. The frequency of their ideations, what their plan is, if they've had past or current behavior or attempts, some aborted attempts, what their real intent is, if they truly, basically, if they truly want to die. And then with that evaluation, you can assess whether they're low, moderate, or severe risk. And then the prevention part is developing a safety plan, doing lethal means prevention, and a crisis referral if it's needed. And then disposition, treating depression if appropriate, and planning follow-up and providing take-home resources. This is really important for pediatricians because you tend to be the trusted expert for the family and the patient. So first we'll talk about screening. You're going to see this outline frequently to remind us of our plan. So who do you screen? All patients age 10 and up who are new, an existing patient that's not been screened within the past 30 days, patients with a positive suicide risk screen at the last screening. If their medical complaint triggers you to think, I'm not sure about this patient's mental health status at this moment, that's clinical judgment. And if they're a well child visit, age 10 or up, this is what's recommended by the mental health section of the NIH. Age 8 and up, if they've had a previous behavioral health complaint or a psychiatric chief complaint. So what do you use as screening tools? Well, the PHQ-A, which is basically the PHQ-9 adapted for adolescents, and the ASQ, Ask Questions, which is, and I'll talk about that. Both of these, the PHQ-A and the PHQ-9 are screens for depression. They only have one question on suicide. If you add the ASQ, it has a very high sensitivity and specificity for suicide. So the bottom line is if you only use the PHQ-9 or PHQ-A, you're going to, and the only question for suicide is question 9, you're going to miss 56% of suicidal patients. This is data collected by Dr. Lisa Horowitz at the NIMH. If you're using the PHQ-9 or PHQ alone without question 9, I mean, by itself, 32% of patients are missed. There are other screens for depression and other screens for suicide. And I'll briefly talk about that. But if you use the PHQ-A or PHQ-9 plus the ASQ questions, you have the best chance of catching those patients who are suicidal. And the PHQ-9 questions you're pretty familiar with. And then the ASQ questions. Have you wished you were dead in the past few weeks? Have you felt that your family would be better off if you were dead? And in the past week, have you been having thoughts about killing yourself, or have you ever tried to kill yourself? Those 4 questions, if the patient says yes, then you're saying, are you having thoughts of killing yourself right now? And how do we score? The PHQ-9 or PHQ-A, basically their options on a screening form are not at all, several days, more than half the days, or nearly every day. And you put the number of items that the patient checked, and then multiply nearly every day by 3 or more than half the days by 2, and you have a total score. 10 to 14 is moderate depression, 15 to 19 is moderately severe depression, and 20 to 27 is severe. And then the scoring of the ASQ, if the patient says no to questions 1 through 4, you don't really need to ask question 5, and no intervention is necessary. But if the patient answers yes to any of questions 1 through 4, they're a positive screen. You ask question 5, and that if yes to question 5, that's an acute positive screen and imminent risk is identified. If they said yes to questions 1 through 4, but no to question 5, that's considered a non-acute positive screen. There's potential risk, but not imminent risk. And then you move on to a suicide safety assessment. There are other additional screens that I've included here because some of our practices in South Carolina use these consistently. If they have a positive PHQ-9 or PHQ-A, they will then go on to use a Columbia Suicide Severity Rating Scale or a Suicide Behavior Questionnaire. Your options, though, if you have the positive initial screen, is to have the discussion with the patient directly. And it's important to let the patient know that other people have these thoughts. Other people their age have these thoughts. It's not uncommon, so that they don't feel quite so alone with those thoughts. This is just an example of the CSSRS that some of our practices use, and the SBQR, which also some of our practices use. I want to talk a minute about the interview questions. The HEADS assessment has been around for years and years, probably about 40 years. And it helps us remember those areas to really ask questions about: home, education and employment, eating, activities, drugs, sexuality, suicide or depression, and safety. It is important to praise the patient for discussing their thoughts and to interview them alone initially. Then it's important to interview the patient and the parent together. Whether you do that first or second, it's up to you and your clinical judgment. But it is important to discuss recent social stressors, and sometimes the patient will not bring these up. I've had that happen often in the clinical setting, but the parents will bring that up. And remember, strengths-based and culturally sensitive. These are just sample questions that the American Academy of Pediatrics have issued to ask about. Down here at the bottom, I think it's important to say, do you ever harm yourself? Do you ever carry a firearm? Have you ever carried a firearm for protection? And do you feel so upset that you wish you were not alive? So after you have realized that the patient has a positive screen, then you want to assess the patient for all the factors that are going to influence whether that patient is going to make a serious suicide attempt. So important factors: previous suicide attempts. That is a predictor for more suicide attempts. Mental health diagnoses such as depression, major depressive disorder, or other mental health diagnoses in the adolescent population. If they're using alcohol or drugs, acute precipitants like the death of a friend or a family member, especially by suicide, if they're being bullied or having relationship problems. I've frequently had teenage boys come in suicidal because they had their first loss of their first girlfriend, and it's a heartbreak. And they don't realize that life can go on at that moment. If they've had a history of trauma, this is very, very important. A lot of our patients have a history of trauma, and we don't really realize that unless we ask the questions. Family history of suicide, and if the patient has a physical disability or chronic illness, that puts them at higher risk. Then we want to assess what their internal feelings are. Are they feeling hopeless? Are they very impulsive? Aggressiveness in the research studies has been identified as a really significant predictor of suicide success or suicide by death. So we need to assess whether the patient is becoming more and more aggressive. The feeling of isolation, whether they have lethal means available to them, if they're giving things away, if they're already hurting themselves, if they have not been able to access mental health treatment in the past, even though it's been recommended and appointments have been set up, or if they're just unwilling to seek help. The protective factors are really what we call resilience. What is their coping ability? What is their frustration tolerance? Are they able to problem solve? And we know that teenagers are concrete thinkers up until around the age of 15, and then they can develop some insight. But if they've been a victim of trauma or a victim of abuse, their ability to go from developing concrete thinking to developing insight in the age range of 15 to 19 is limited. So that comes into your assessment of the patient. How adaptable are they, and what is their self-esteem? Frequently, these patients have very, very low sense of purpose or self-esteem. Do they have positive therapeutic relationships with counselors, with family members, with friends? And do they have family and friends who are culturally sensitive and good support? I think it's important to also assess the parental skills. Is a parent going to be able to monitor and support this patient in your attempt to provide suicide prevention? If not, that's significant. And then what their beliefs are. They may have cultural, religious, or personal beliefs that discourage suicide. So,
Dr. Woods, just 5-minute warning.
okay. So the suicide inquiry includes assessing how frequent their thoughts are, what their plan is. Have they had past attempts or avoided attempts? Have they rehearsed? Frequently, patients will tell you, yeah, I put the gun to my head, but then I took it away. That's a rehearsal. And what extent the patient expects to carry out the plan and believes that the plan is lethal. Those are important. And these are the suicide inquiry questions which assess that. Then we move on to the level of risk. Low risk, they have modifiable risk behaviors. They have strong protective factors. They have no plan, no intent, no suicidal behaviors. Moderate risk, they have a few protective factors. They have an ideation with a plan, but maybe no intent, and no suicidal behaviors in the past 3 months. 3 months is important. If they've had suicidal behaviors, according to the research, within the past 3 months, that puts their risk at a higher level. If they've had unmodifiable risk factors, psychiatric diagnoses, symptoms including aggression, acute precipitating events, a lethal suicide attempt in the past, or it's a potentially lethal suicide attempt, these are all, and in the past 3 months, these all identify severe risk in the patient. So what do we do? Well, all patients who are positive for screening should be counseled and receive lethal means safety prevention. If they're moderate risk, then their mental health referral may be required and follow-up. Don't forget the follow-up. If they're severe risk, they may require a crisis referral. And even if you make a crisis referral, be sure to plan follow-up for that patient. It may be after they've been seen in the emergency room, but be sure you follow up with the patient. This is an example of a safety plan. There are 6 elements. Warning signs, what are their coping strategies, who provides distraction for them, people they can ask for help, professionals I can contact. Now, if you list people in this, people I can ask for help, those people need to know they're listed on a safety plan. Professionals need to know they're listed on a safety plan. So please make sure that when you make a safety plan, you address all of these issues. And then the lethal means safety is making the environment safe. So I think it's important to know what words we can use. We can say to the patient, sometimes people struggle and have a crisis and experience those strong, intense suicidal feelings. I'm not saying this is likely to happen, but if it does, I want to make sure you make it through safely, get the help you need, and then ask if you can talk over the plan. To the parent or the caregiver, you say, if the patient is going to attempt suicide, it's usually at home. It's a quick, impulsive decision. So the more time and distance you can put between the method that could do serious harm, that's the most important, effective step. Pills are the most frequent method of attempt, and guns are the most lethal. So start with those in terms of discussing lethal means prevention. Firearms, medications, belts and ropes, and sharp objects. Particularly firearms, it's important to make sure they are stored safely. All of us in our practices have heard of or had families who experienced a death from an unintentional death from a firearm that was not safely stored. We don't want that to happen, but we also don't want our suicidal patients to have access to both a unlocked and loaded firearm. Be sure that all old medication is either disposed of, and when you prescribe limited quantities for these patients. The most common medications that are used for suicide attempts are opioids. These are available in every home in the United States. I would bet my bottom dollar. These are prescriptions that people have saved or left over from an injury or a surgery. The other drugs are the benzodiazepines. These are frequently also in every home. Antipsychotics, antidepressants, this is where we can have a significant impact by being careful about what we prescribe and how much we prescribe. Sleeping pills, and also don't forget the over-the-counter drugs. Frequently Tylenol is used, acetaminophen is used as a suicide attempt. Use lower toxicity medications like SSRIs or SNRIs. Try to avoid the tricyclics because the toxic quantity and the therapeutic quantity are very close in tricyclic antidepressants. Consider weekly refills instead of a month worth of medication. And remember that the patient may be using other drugs or alcohol. So if you have a severe risk, you make an immediate referral for a mental health evaluation, usually in the emergency room. Don't leave the patient alone in your office unless you're watching them, and remove any dangerous objects in your exam room or wherever the patient is seated. I've had patients in a exam room attempt to use the tongue blades to strangle themselves, gagging until they wanted to choke. Anyway, make a safety plan for prevention, do the lethal means prevention counseling, make a mental health referral, and treat the depression if you're not immediately sending the patient to the emergency room. I know not everyone is 100% comfortable with treating depression, but it is important. So let me just make a comment about depression. When I treat depression, I talk about the three-legged stool. Medications will help, but therapy is also significantly important. And exercise is the third leg of the tool. You got to get the patient up and moving. So the combination, if you start medication and therapy at the same time, works the fastest to achieve remission. Frequently in the past, we've said, let's do therapy first, we'll wait on the medications, and that leads to a slower achievement for remission of the depression. So if you combine, for example, in this study, Prozac and cognitive behavioral therapy, there was a response rate of 73% within 3 months. That's very significant. But if you just do counseling alone, it's 48% in this particular study. And this has been replicated in other studies as well. So your choices include the SSRIs, which are usually the first line, and then SNRIs, which are norepinephrine reuptake inhibitors, the TCAs, which we want to avoid, and there are some others that are available for antidepressants. All of the SSRIs have a box warning, and this used to be called the black box warning. But the bottom line is that the patients will benefit from treatment much more than there's a risk of suicide in that group of patients. It does require monitoring. Now, how do you make your decision? Well, lots of factors based on diagnosis, the efficacy of the medication you're trying to choose, the family history. It's important to ask, have other people in your family taken, for example, Prozac? The cost is important, the side effects we need to explain, and if the patient has had any type of genetic testing that included pharmacokinetic genes, that can be considered as well. So 6 times more teens will benefit from antidepressants than are harmed. So even though there's a box warning that we have to explain, and I say to patients and parents, there is a warning for this medication. So if you start feeling more suicidal thoughts or more intense suicidal ideation, call. You have to call me, stop the medication, and please call. You also need to explain that it takes 4 to 6 weeks for some of these medications to be efficacious. Lexapro is about the fastest working one, but of course does not have an FDA indication below the age of 18. You want to ensure that they understand the instructions. In terms of adolescent confidentiality, if you are dealing with the patient alone, safety trumps privacy. So if you have a patient who is suicidal and they don't want you to tell the parent, I'm sorry, you have to involve the parent or the guardian. Warn the patient of all these things, that if they're have more thoughts of self-destructive behavior, more suicidal thoughts, increased anxiety, or even increased elation, they're having manic type speech, any of those things, after you've started an antidepressant, they need to call you and schedule follow-up for that patient. Some people, what I do is a 2-week telephone call follow-up and a 1-month office follow-up. So that referral, after you've called the ED and relayed the important information, make sure you confirm an appointment with you. Because what we know from this research is that collaborative care with mental health providers is very important. And in depression response, those patients whose primary care providers collaborated with their mental health providers, 67.6% had a depression response versus only about 38% whose providers did not collaborate. So it's really important to get the family and the patient and the providers engaged, all talking with the same language. Sorry. Patient resources, there are many prevention smartphone apps. You can find one that's important. Some of our practices in South Carolina use the My3, and they go over the app with the patient. They put the safety plan in the app. There are also crisis lines, and I think it's really important that every patient, every family walks out of your office with this information. And that's all the information I have to share with you. These last few slides, basically, the bottom line is that if you reach out to your patient and you're intent on helping them recover from their suicidal thoughts, their suicidal ideations, their suicidal attempts, you can do this. It's painful sometimes, and the bottom line is their story isn't over.